Hello, everybody. Welcome to our May ICARE Genetics Case Conference. I'm Tua Pal. I lead ICARE. So just wanted to start off with some housekeeping in terms of ICARE referral numbers. We continue to grow at a fairly large rate. We thank our top recruitment sites, both for this month as well as for the year to date, as well as the many of you that attend these case conferences. As you already are aware, probably we are able to accept referrals both through the ICARE website, or if you want, we can send you prepaid postcards. As well, for these case conferences, we really like for them to be interactive and a partnership with our provider partners. So please feel free to submit cases that, again, may or may not be aligned with the theme of the case conference. And we've tried to make it as easy as possible through this submission link. It comes directly to us, and we're happy to help you prepare the case if that's something that you need assistance with. In terms of ICARE focused efforts, we continue to recruit fairly steadily to our impact study, which is testing strategies to improve guideline adherence, cancer risk management, as well as family communication among those with inherited cancer predisposition. So tested positive for an inherited cancer predisposing gene. On top of that, we are continuing to recruit for our genomic characterization of breast cancer study, where again, we have specific genes where we are recruiting individuals with breast cancer and an inherited gene mutation in one of the genes listed. So again, we're getting to the point where we have almost 200 recruited. We thank everyone for their support for this study as well. We have another study, again, if this is helpful, this is again open across the country with like being able to refer patients, but we're trying to, again, test strategies to automate and streamline genetic education. And again, this is under research, so this is not anything to do with us taking over any of your patient care, but just to get some of the pre-paperwork and assessment stuff done for patients, whether they've had testing or want to get testing. And again, we've automated a lot of those processes. So if you want to share this or check it out, here is the REDCap link. We're happy to give you more information about that as well. And then again, these are some of the resources that we offer through ICARE, which I think most of you know about. Our latest social media posts for this past month. Again, we try and be active on social media across various different objectives, whether it's talks. Again, as we do these guest expert presentations, we do post them on our YouTube channel. So even if you can't attend each ICARE case conference, they are available for asynchronous viewing. And as guidelines change or as other information or research or clinical updates become available, we do post regularly on our social media platforms. I wanted to also make folks aware of this Hereditary Breast and Ovarian Cancer Symposium that happens every couple of years. So the one, and it happens in Montreal, hosted by my colleague, Dr. Will Fowkes, and it is really a phenomenal conference. I would encourage folks to check this out. Again, a couple of weeks ago, there was another cancer genetics conference that we publicized that Dr. Fumio Lapati hosts in Chicago. But again, I would say along the same lines, Will's conference is really phenomenal. You can, if you want to be on the mailing list, you can just go to BRCA Symposium. There should be a .com, I think, here. But anyways, and again, it really is, it's a 3-day conference. It's in Montreal, which is beautiful. And he brings in really world-class speakers for this. So check it out, see if it might be of interest. And then NCI Cancer Genetics PDQ editorial board. Again, I chair this effort, the cancer genetics piece of it. And it's an underutilized resource, but there's a lot of rich information there. We do updates of these summaries across disease sites, all focused on inherited cancer predisposition. We do this on a monthly basis, and we're working towards gene-specific content. So again, if of interest, please check it out. So with that, I wanted to start with the first case before I went ahead and introduced our two guest speakers who will comment on this case and then go on with the presentation. So as everyone knows, this is an SDHA focused case conference. So this first patient was a patient I saw, 31-year-old female. Her son was evaluated through pediatric genetics through our undiagnosed disease program due to a history of failure to thrive, short stature, and other things associated with what a pediatric genetics clinic would see. So multiple malformations. Full exome sequencing was done on a trio. So the son as well as both parents, and the son was found to have an SDHA C223C to T variant, which is classified as pathogenic, and it was maternally inherited. Of note here, I'm going to go on to the pedigree. So here is the proband that I saw, the 31-year-old with the SDHA. The son was original individual that was tested where this came to attention, but then subsequently the patient's sister, so through her mother, was also tested and found to be positive, as was the sister's 16-year-old son, who had osteosarcoma at age 12. And then the patient's mother had a pituitary tumor diagnosed, I think it was at 53 or so, resected. I don't have pathology on that, but she's alive and well at age 59. So really, I wanted to pose questions to our guest experts. This SDHA is an incidental finding. Do we take the pituitary tumor into account? What are the next steps? But before I do that, let me just introduce our guest speakers, which is Dr. Helen Hanson, who's a consultant in cancer genetics at the Royal Devon University Healthcare NHS Foundation Trust in Exeter, UK. She's also a NIHR Senior Investigator Fellow, Faculty of Health and Life Sciences at the University of Exeter. And again, is actually the lead individual for the SDHA guidelines that came through the UK group, published in the Journal of Medical Genetics, I believe, within the last few years. And then we have Dr. Ruth Casey, who's a consultant endocrinologist at Cambridge University Hospital, NHS Foundation Trust. She's a senior research fellow, Department of Medical Genetics at Cambridge University. So you can see how medical genetics in association with endocrinology would really rounds out this case conference and the expertise that we really are wanting for some of the cases that we're finding. So I'll go back to my last slide. And Dr. Hanson or Dr. Casey, do you want to comment on some of the questions or some of your thoughts?
So I think hopefully we'll address some of this in our upcoming slides. But I think just to confirm, because I think it is this lady here who's had the pituitary tumor.
Correct.
Okay.
Yes.
So the grandmother of the proband that you saw in clinic.
So the proband I saw was a 31-year-old, so her mother.
Okay. Okay, but it was the son who had the testing originally for the so I think that ideally we would want to try and do immunohistochemistry on that pituitary tumor to see if this is an SDHA associated tumor. I know you mentioned that you were having difficulty in getting hold of the histology report. I'm not sure if that was the blocks or just the report for that.
It's a different system. In the US, we have a very fragmented healthcare system, as you probably know. So getting anything beyond what's in our hospital system and for another individual is really not always feasible.
Yeah. Helen, might jump in. So I mean, I suppose the reason why the pituitary tumor in this situation is, I suppose, is so important in that it's the only potential SDH associated tumor that we see in the pedigree, and it would inform whether or not we would advise whether any of the individuals who carry the SDHA pathogenic variant would benefit from clinical surveillance for SDHA associated tumors. So if we don't have access to the tumor, then if we think, so I think we have to think about the phenotype of that grandmother. And so she was in her 50s when she developed. And was it do you know if it was a small or so was it a micro or a macro adenoma? Do you know? Pituitary tumor, you don't know.
The patient didn't know what I mean, if we could get a pathology report, you think that would potentially help here? Okay.
Because if it was a microadenoma, they're very common in the background population. So, and just to flip this on its head, for example, the grandmother would not meet the UK criteria for genetic testing for her pituitary tumor based on her age of presentation, even if it was a macroadenoma. And also, just to give some context, in the UK, this is unpublished data, but we have looked at 200 pituitary tumors, and we have done SDHB immunohistochemistry to see how many of those just incidental pituitary, or not incidental, but so-called sporadic pituitary tumors would harbor an SDH mutation, and we basically found 1 in 200 cases. And that particular case had very specific histopathological features. So they get these intracytoplasmic inclusions that are very pathognomonic of an SDH deficient pituitary tumor. So if you could get hold of the histology report, and if there was any unusual features, then that might help. But otherwise, based on the patient's age, because when Helen and I looked at this slide last night, we thought that it was the mother, the 31-year-old. So that was looking a bit more suspicious because she was younger. But if it was in her 50s, then that looks much less suspicious. And I would say that that is unlikely to be related to the underlying SDHA mutation based on the phenotype, but it would be nice to have the pathology. And in an ideal world, you'd love to have the immunohistochemistry. But I think based on that information, if we can't get any additional information, then I think it's very unlikely for that pituitary tumor to be related to the SDHA variant that's been picked up incidentally in this pedigree, would be my opinion.
Thank you so much.
We
will go on to your presentation.
Okay. Okay. So thank you very much for the introduction, and we're doing this as a double act, so I'm going to start and then Ruth is going to come in the middle, and then I'm going to finish it at the end, and hopefully we'll be able to talk to you through some of the features associated with germline pathogenic variants and SDHA, and how we would currently manage these in clinical practice in the UK, and how we have started to think about reporting these variants when they're found incidentally. So I'll go through a bit of an introduction. We'll talk about the tumours that we currently think are associated with SDHA. We'll talk about the penetrance data that currently exists from a number of different studies. We'll think about the key clinical considerations, and I hopefully highlight some take-home messages about the tumour types and metastatic disease that can occur. And then we'll finish off by talking about the paper that Toya mentioned about the recommendations that we have in the UK. So SDHA germline pathogenic variants, as I'm sure you all know, but for those of you who are not aware, they're identified in around 10% of patients who have paraganglioma and pheochromocytoma, or PPGL. they actually identified a much higher proportion of patients who have wild-type GIST, so up to 30% of patients who have wild-type GIST will have an SDHA pathogenic variant, and that's higher if the patient has been shown to have SDH deficient GIST. Now, there's a number of papers which have suggested association with other tumour types, and certainly, you know, when this has been found in the setting of tumour testing, there's always a question about the association of SDHA with those tumour types, but that is much less well established, and still, I think, you know, our understanding is emerging. And what's important to understand is that these variants are frequently identified in patients who don't have a relevant family history, which is why they can cause, you know, problems in our clinical practice when we're trying to think about how to advise other family members. So our current understanding is that we think that wild-type GIST is strongly associated with SDHA pathogenic variants. Also, paraganglioma and pheochromocytoma have a strong association, but we would want to ensure that other PPGL genes have been excluded. And then when we think about renal cancer, neuroblastoma and pituitary adenoma, which we've just discussed, the association with these is less strong, and we would recommend, where possible, as we've already discussed, undertaking immunohistochemistry to see if that tumour is likely to be associated with that SDHA pathogenic variant. And we would recommend doing that where possible before we would say that variant is causal of that tumour. So thinking about the penetrance, so there's been a number of studies of the penetrance of SDHA germline variants, and I just wanted to highlight a few of these. So the first was in 2017, and this was a prospective study, and it was an international study, and they had a number of patients, so just less than 1,000, where they were looking at patients who had already had variants excluded in classic PPGL genes, and they identified 29 SDHA heterozygotes. And they demonstrated that by the age of 40 years, the penetrance in the heterozygotes was around 40%. However, when they broke this down further, they found there was quite a significant difference in the index patients versus the non-proband. So they found that in family members, the penetrance was much lower, around 13%. But you'll notice the numbers were very small, and they only had 9 patients included who were non-probands. So then there was a later study from the Netherlands where they did a retrospective study, again looking at patients with unexplained PPGL, and they had a slightly higher number of SDHA heterozygotes. So they had 30 heterozygotes, most of whom who had presented with head and neck paraganglioma, but they also had 56 non-index heterozygotes, and they were able to demonstrate that in most of those families, the SDHA had been inherited from a parent who was unaffected with any SDHA-associated tumour. And this study demonstrated again that the penetrance, when you were looking at the non-probands, was around 10%. Although they did highlight, and Ruth will come on to this as well, that in the index cases there did seem to be a young age of presentation, or that individuals could be affected with metastatic disease. And then there was a couple of later studies where the penetrance was assessed more on a population based level. So there was this study initially by Benetau who looked at controls from Exeter, and then there was a later study looking at NOMAD and also literature based PPGL cases, and both of those studies showed that on population base level, the penetrance was much lower, so ranging from 0.1 to 5% in these cases. So very different from the studies where they had ascertained cases through individuals diagnosed with PPGL. So the key messages here are there are a small number of studies. These are probably the only studies that I could find in the literature. The penetrance in non-proband family members is probably around 10 to 15% lifetime risk. The penetrance in population-based studies is even lower, so around 1 to 2%. But importantly, these studies don't specifically address the risk of gastrointestinal stromal tumours and are only looking at PPGL. So I'll now hand over to Ruth, Dr. Casey, who can talk through a few cases from her clinical practice.
Thanks, Helen. So yeah, I'm going to start with the case. So this is a case of a 15-year-old female. So she initially presented with an upper GI bleed, and at the time of her presentation had an emergency endoscopy, at which time she was diagnosed with a tumor in her stomach, which on biopsy turned out to be a gastrointestinal stromal tumor, or a GIST. She then had a CT scan, which demonstrated that she actually had metastatic deposits in her liver, as you can see highlighted by the red arrows, but she also had peritoneal metastases not demonstrated on this single image of her CT scan. Subsequent molecular analysis of her GIST tumor showed that she had what's called a wild-type GIST. So this basically means that she didn't have a activating mutation in KIT or platelet-derived growth factor alpha, which are the two mutations that we commonly see in conventional GIST. So because her GIST was a wild-type GIST, she qualified for germline genetic testing, which includes all of the succinate dehydrogenase genes, so SDHA, B, C, and D on the UK panel. And she was diagnosed with this common truncating variant, pathogenic variant in the SDHA gene. So of note, she had no family history, although subsequent cascade screening identified multiple family members that were carriers of this variant. There was no other history within the kindred of, or within the pedigree of SDH-associated tumors, GIST or pheochromocytomas or paragangliomas. So now 18 years later, that should read. So she is now 33, this patient. She is still alive and reasonably well. She's had slowly progressive disease on various treatment options, but there's been no further evidence of tumors within her family, and she herself has not developed any other new tumors. So she has not developed a pheochromocytoma or paraganglioma or any other, or renal cell carcinoma, for example. So this patient is typical of the type of patients that we see in our national GIST clinic with SDH, pathogenic SDHA variants. So if we look at GIST cohorts, so we look at our UK data. So this is unpublished data. So in Cambridge, we actually run the national pediatric and adult wild-type GIST clinic. And in our clinic, we have, over the last number of years, seen 40 patients with wild-type GIST that have been well phenotyped, and we have for whom we have genetic data. Within the cohort of SDH deficient wild-type GIST, you'll see that the most common SDH subunit affected is the SDHA gene. So it's the most common of the SDH genes implicated in patients with wild-type GIST in our clinic. And if we look at some other large cohorts, if we look at the NIH data, this is published data. In the NIH, again, in the SDH deficient wild-type GIST cohort, the SDHA gene is again the most common of the SDH genes implicated in wild-type GIST. And again, if we look at the two other largest cohorts that have been reported to date, so this would be a cohort from Italy and a cohort from Australia. Again, SDHA is the most common of the SDH variants implicated in SDH deficient wild-type GIST. So again, if we continue on the theme of SDHA variants and wild-type GIST, the most common of the SDHA variants that we see is typically the most common variant that we see in anyway in clinical practice, which is this truncating variant here. Again, what's very unusual is that although we see probands who can present with metastatic disease at a young age, what we're seeing, which is in line with the penetrance data that Helen has just shown us, is that it is very rare for us to see other family members carrying the SDHA gene presenting with GIST tumors or having a history of GIST tumors. And in fact, in the literature, there have been only 3 reported kindreds where more than one affected family member has been affected by a GIST. So of the reports that I know, there are 2 kindreds where there's 2 sisters carrying SDHA variants, both of whom developed GIST. And the other kindred was one that we reported from Cambridge, where both a mother and son carrying an SDHA variant developed a GIST. So Despite there being very low penetrance within families, we do note that about 20% of patients who have SDHA variants and have GIST will have metastatic disease at presentation. But it is very rare for those patients who present with a GIST to then go on and develop a different type of synchronous tumor. So, for example, it's very rare for a patient with an SDHA variant to present with a GIST and then subsequently develop a paraganglioma years later. And we don't quite understand why that is. Because the opposite is quite the opposite. We see the opposite for patients who present with paragangliomas who have SDHA variants, for example. It is a bit more common for those patients to have synchronous paragangliomas than for patients who present with GIST. One observation that we have made over the last number of years, both in our clinic but also in the NIH clinic, is that patients with germline SDHA variants who have wild-type GIST will frequently have the co-occurrence of a epi mutation. So this is promoter hypermethylation at a tumor level, affecting the SDHC gene. And that's relevant in terms of the expected phenotype, because some of you may be aware that SDHC epi mutations are associated with what's called Carney's triad. So that's the co-occurrence of a pulmonary chondroma, a paraganglioma, and a GIST in an individual. And we used to think that Carney's triad was very specific for SDHC epi mutations, but we're now noting that patients can have both an SDHA germline pathogenic variant and a coexisting SDHC epi mutation. And when that happens, those patients can also develop Carney's triad. So it's not unusual for patients with an SDH germline variant to develop Carney's triad. Okay, so then moving on from GIST, so this is the second case. So this is a 21-year-old male this time. So he presented with hypertension to another center. And at that time, which was 23 years before I eventually met this man, he was diagnosed with an abdominal paraganglioma. Following on from his surgery, because this was 23 years ago, genetic testing was not commonplace at that time, and he was actually lost to follow-up and represented when he was aged 44 with hypertension to his GP, who thankfully was astute enough, given his history, to refer him into the endocrine clinic quite quickly. And he had, at that time, biochemistry, which demonstrated that he had very elevated normetadrenaline levels, as you can see here. And obviously, given his history of a paraganglioma at quite a young age, we were suspicious that this man either had a new paraganglioma or a potentially metastatic recurrence. And basically, he did end up having a metastatic recurrence in a single rib, as you can see from the CT scan, and then the FDG PET CT, which is in panel B. Interestingly, he did not have evidence of MIBG uptake, and that's what this scan is here in panel C. And panel D, you'll have to take my word for it because it's quite small, but this is SDHB immunohistochemistry, which is showing loss of the SDHB protein in his tumor. And actually, this patient was subsequently diagnosed with a germline SDHA variant, so he had the same truncating variant, common truncating variant that I showed you from case 1. So he had surgery or surgical resection of this rib in 2018, and unfortunately in 2022 developed subsequent new bony metastases that you can see here on his FDG PET, so in his spine and pelvis, but thankfully that disease has remained reasonably well controlled with slow progression over the last 2 years on oral chemotherapy. So his tumor is behaving quite indolently, but he is a case of paraganglioma who had metastatic recurrence. And I think what's really notable for his case and other reported cases of SDHA mutated paragangliomas in the literature is that there can be quite a lag between initial surgical resection and metastatic recurrence. So I think this really highlights the need for lifelong follow-up for these patients with SDHA variants. So if we look at SDHA and pheos and paragangliomas, so about 40 cases have been reported to date in the literature. The most common location of pheos and paragangliomas in patients with SDHA gene variants is in the abdomen and pelvis. The estimated malignancy or risk is about 10 to 15% for these patients. And although it's more common for a patient who presents with a paraganglioma and an SDHA variant to develop a subsequent synchronous paraganglioma than it is if the patient presents initially with a GIST, we still see that it's less common for the SDHA variants to develop synchronous tumors in general than it is, for example, for patients with B and D variants. But as I've shown you from this case, and as we know from larger cohort studies and retrospective series published in the literature, patients with SDHA variants and fusion paragangliomas can develop a metastatic recurrence or can be metastatic at presentation. So before handing back to Helen, I just want to briefly discuss how we screen carriers of SDH variants, and really just to highlight that although the penetrance of the SDHA variant is arguably lower than we see for SDH B, C, and D, the screening for asymptomatic carriers in kindreds where the variant is identified because of a SDH-associated tumor, the screening for SDHA carriers should be the same as it is for B, C, and D. Needless to say, any screening program has to balance the benefit of early detection versus the low penetrance. But we also have to, take into account the malignancy risk associated with the specific gene. The screening program has to be able to detect both secretory and non-secretory pheos and paragangliomas. So what I mean by that is tumors that are making catecholamines and not making catecholamines, because some of the pheochromocytomas and paragangliomas that these patients can develop may not secrete catecholamines, and so you may miss them if you just do biochemistry alone. We obviously have to consider the radiation risks from multiple scans and take into consideration patient anxiety. And obviously there's the issue around healthcare, health economics, and the risks and benefits of these kinds of screening programs. But hopefully most of us are now adhering to the most recent international consensus on what the screening should be for asymptomatic carriers of a pathogenic SDH gene variant. And basically what the guidance is now is that any adult carrier identified with a pathogenic variant in A, B, C, or paternally inherited D should be referred to an endocrine clinic, should have blood pressure and heart rate checked at first visit, should have clinical history taken, and should have biochemistry, which should either be plasma-free metanephrines, ideally, or urinary metanephrines. And at their first visit, the patient should be offered a full body scan. And we are advocating for MRI because of the obvious radiation benefits, i.e. there's no ionizing radiation with MRI. And if at the first visit the patient has a negative screen, then that patient should be followed up every year and have a blood pressure, clinical review, and biochemistry, but we'd only recommend interval whole body screening every 2 to 3 years. So like I've said, we would tend to opt for MRI over PET-CT to spare radiation. And the other thing is to say, when do we stop screening for these patients? Well, we typically would recommend increasing the interval between imaging once the patient gets to 70, if they haven't had any development of a tumor by that point. And certainly we would completely stop screening by the time the patient reaches 80, if they have remained well from the point of view of tumors at that time. When do we start screening for children? Well, this is a difficult question, and one that most of our patients, it's usually the first question that our adult patients will ask if they have children is, what about their children, and when do we screen them? And a couple of years ago, we looked at the age at which children present with tumors that are subsequently diagnosed with SDH variants. And what we found was that it's very uncommon for a child with an SDHA or an SDHC variant actually to present under the age of 10 with a pheochromocytoma and paraganglioma, and it was really only for SDHB carriers that we saw any penetrance under the age of 5. So that has led to the recommendations around when to screen children, and basically for SDHB carriers, we recommend that they're genetically tested at the age of 6, and if they carry a pathogenic variant in SDHB, then they should be clinically and biochemically tested from 6, and we should think about some imaging when they get closer to 10 years. But for A and C and D, genetic testing should be 10 to 50 at the age of 10 to 15 years, and then if the child carries the pathogenic variant in A, C, or D, then we would start clinical, biochemical, and radiological testing between 10 and 15 years, so slightly later than for B. Okay, so at this point, I think I'm going to hand back to Helen to finish the presentation. Helen, I think you're on mute.
Thank you. So we've heard about cases where that are seen in the endocrine clinic where patients will have an SDHA associated tumor, and identifying an SDHA pathogenic variant in that context, and the surveillance that then we would consider offering to family members who are then found to have that variant. But one of the problems that has occurred in clinical practice over the last few years is that we are increasingly finding having incidental findings, not just for SDHA, but other cancer predisposition genes. And this really came to light, I suppose, as a result of the 100,000 genome study in the UK, where there were many patients who had large panel or whole genome sequencing because of varying indications, and there was a number of patients who were found through the study to have SDHA pathogenic variants. And so really the guideline that was developed was on the back of that study, and lots of different genetic services discussing how best to manage these patients. And so the things that we really wanted to consider is that when we identify one of these variants incidentally, we know from the penetrance data that most heterozygotes will not develop any SDHA related tumours. However, as Ruth has highlighted, in contrast with that, we have patients who present with SDHA related tumours who can present at young ages and can present with malignant tumours. So it is very difficult to consider the low penetrance, the risk of malignancy, and also the surveillance burden, not only for the patient but also for the healthcare system as well. So what we did was we'd had a group of scientists, endocrinologists and geneticists who all came together and had a discussion about how we address this in our clinical practice. And so this paper was published, I think, at the beginning of last year, but the discussions went on for quite some time before that, probably around 18 months. And the first thing that we did was we felt it'd be helpful to define what we felt were on-target or SDHA-associated tumours. And so these are really the tumours that I mentioned at the beginning. So wild-type GIST, paraganglioma, and pheochromocytoma, and also renal cancer, neuroblastoma, and pituitary adenomas, where there's immunohistochemical evidence of SDH deficiency. And in those situations, then we would obviously report the SDHA pathogenic variant. We'd offer surveillance for the affected probe and lifelong. We'd offer predictive testing to relatives, and then offer the recommended surveillance as highlighted by Dr. Casey. In the situation where we have an individual who has a non-SDHA associated tumour, then and so this may be identified through large somatic panel testing, or maybe paired germline and tumour testing. In these situations, we would recommend that immunohistochemistry could be performed on the tumour to look again for immunohistochemical evidence of SDHA deficiency. And then in situations where that was demonstrated, then we would consider that this was related to SDHA, and would then report that variant and offer the recommended surveillance for the patient and for their family members. In the situation where there doesn't appear to be that causality and that association, then we would the surveillance, we wouldn't offer ongoing surveillance, and we wouldn't be recommending cascade testing out to other family members. And obviously these discussions would take place in a GTAB or genomic or molecular tumour advisory board, and we would have information also available on relevant family history or other personal history which may be relevant. Oh, sorry, it's slow to advance. And in the situation where a decision was made to report that SDHA variant, then we would also recommend that the lab highlights the low penetrance of variants, particularly in the setting where there's no relevant family history. And we would also recommend that predictive testing of other family members is offered in the context of a clinical genetics appointment or consultation. And we thought it was also really helpful to think about those discussions regarding predictive testing, and having that informed discussion with patients, highlighting about the difficulty of surveillance in this condition, particularly due to the association with GIST, and the surveillance we're offering is for PPGL, the low penetrance. And we also felt that it was really important to have discussions of the symptoms that can relate to SDHA associated tumours, and discuss with patients what really would be the best approach, as a shared decision making process. We wouldn't suggest cascading out the testing to further relatives, so second degree or further relatives, but we would recommend symptom awareness and discussions with those patients. So we recognise that that there is limited knowledge, and what we really need is more prospective data collection to address any outcomes of surveillance or any cancer incidences in people who are found to have SDHA variants, and hopefully in the future we will have more information on which to inform our surveillance recommendations and reporting. But at the moment in our clinical practice, we've been following these recommendations, and obviously having those discussions within our molecular tumor boards or GTABs about specific families where there may be, as with every family, nuances or difficulties in families where you may not have all the necessary information or it's difficult to get. So I will finish there, and I don't know if we have questions or whether we move straight on to cases.
Yeah, no, Helen and Ruth, thank you so much. That was really helpful. So are you saying that first degree you would cascade out, but not beyond first degree?
So we're in this situation where we identify a patient who presents with an SDHA associated tumor, then we would test first degree relative.
But I'm saying, what about incidental?
Incidental, then we wouldn't. But I don't want to say categorically wouldn't, because all of we would have those discussions, and we wouldn't
shared decision making.
Yeah, well, we wouldn't cascade out unless there was a reason to that made a suspicion that we didn't have all of the information about the family, or there was a tumor that we maybe couldn't verify or get further information on.
Okay, let's go on to the case, which Amy George, this is a case that we were trying to present last time, but we ran out of time. It's not going to be on the SDHA theme, but we welcome both Helen and Ruth's input on this. It is endocrinology related. And then we will go back to our SDHA theme. I'm hoping we'll get through at least 2 cases. Amy, take it away.
My patient had an initial referral due to an early onset breast cancer, but basically she was diagnosed with an invasive breast cancer in May of 23, and then a couple months later diagnosed with a right pheochromocytoma, so also at 23. You can see the details of the treatment that she underwent. So within 2 to 3 months span, this 33-year-old had been diagnosed with these 2 diagnoses. It looks like, sorry, something popped up on my screen, so I can't read it. It was resected, so I don't believe she presented with, metastatic malignant disease, and she's just being monitored by imaging. Her germline testing, or this is her pedigree. So again, aside from her striking history herself, not overly overwhelming in her pedigree, but it is a small tree. Mom also had been diagnosed with breast cancer just a couple months after her daughter, but she is, in her late 60s. So that wasn't terribly concerning, and no other endocrine tumors were reported in the family. But she's got 2 siblings and then 2 young children, so obviously concerns there. So She initially had genetic testing that did not include all the genes related to endocrine tumors, just because it had been done due to her early onset breast cancer. So then testing was reassessed and repeated with a larger DNA and RNA panel that included the SDH genes and other genes related to pheochromocytomas and endocrine tumors. And this is what was found, which I know it is uncertain. It is uncertain by several laboratories. But again, going back to the patient, having this striking history, she, is concerned kind of where do you go from there with this type of result. And, we obviously don't know a ton about this particular gene as well, which has been more recently added to larger panels. So this is a tumor suppressor gene. It's associated with non-syndromic pheochromocytomas, but rarely paragangliomas from what I read. This is her specific variant. So this was the information the laboratory included about this specific variant, being pretty rare in general population databases. It has been observed with people with PHEOs. And again, these are algorithms that the lab uses to try to determine functionality, but there's not any concrete data or functional studies to put it in a likely pathogenic or pathogenic classification, hence the VUS. So the patient is followed by medical oncology, endocrinology, and urology. These are our NCCN guidelines. I need to read the paper that you guys just presented. I'm not familiar with that paper because we do have SDHA patients in our population as well. And kind of my question was with tumor testing, is, it would be worthwhile, or I don't even know if it's feasible to see if there is loss of heterozygosity of TMEM127 in the tumor in her PHEO. There has not been any tumor testing done on her PHEO since it was not a malignancy that we are treating from an oncology standpoint. But this patient's very motivated to have more information or more direction. While she will be monitored very closely, she does have a 2 and a 3-year-old and siblings that are close to her age, and understandably so. What should they be doing, if anything? Is there anything that would be even appropriate to consider? So those are the questions.
Okay, Helen, do you want me to?
Yeah, you can please
take it away because we want to be educated.
Well, I think it's fair to say that there's just whatever data we have for SDHA, we've even less for TMEM127. It's so rare. But what we do know is that the penetrance is also felt to be very, very low for this gene. So I suppose there's two questions really about this case. One is the lady's motivation to know more about the potential for the gene variant to be pathogenic or related to her PHEO? Is that because she's worried about her family's risk, or is that because she's worried that it may better inform her kind of long-term surveillance?
I think family, because she's going to be monitored very closely regardless.
Yeah. So I was going to say she should be monitored very closely regardless because of her young age, and all the guidelines recommend that because of her young age, she would qualify regardless of her genetic testing for kind of lifelong follow-up. In terms of the family, and I can only speak for like what we would do in the UK, I suppose, but in the UK, even in the UK, even if we did tumor sequencing and we found loss of heterozygosity, that alone is probably not going to take the variant status up to pathogenic, because based on ACMG, that wouldn't be enough unless we see further, for example, penetrance within the family. That I think that the loss of heterozygosity wouldn't be enough for the variant to be moved to a likely pathogenic variant, and so therefore we certainly wouldn't offer cascade screening within UK practice. What might be useful for this patient that you could do, though, is for her own sake to try and reassure her. So as well as doing loss of heterozygosity, if that's available, the other thing that has been identified, both we published on this, but there's been larger studies from Europe and the US, it is very unusual. In fact, it's very, very, very rare for patients to carry both a driver genetic variant, germline variant, and a somatic variant. So it's very rare for both to coexist. So if this patient was identified with another somatic driver variant, then it's quite likely that the germline variant that you're finding is a VUS and not driving her tumor. So tumor sequencing would be helpful for this patient for two reasons, both to look at LOH, but also to see if she has another somatic driver variant, because then makes it much less likely that her TMEM127 variant caused her FEO. So that could be helpful. But I certainly, in my practice, if I was refer this patient, I would follow the patient, but I wouldn't be offering screening to her family. I don't know, Helen, if you have anything to.
No, yeah, I know, I agree. I think, you know, we wouldn't offer testing without any further evidence becoming available. And I agree, I don't think the loss of heterozygosity second hit is going to be enough to kind of push it over the line. It will need something else. But I think what you suggested sounds very reasonable for her reassurance.
So I understand if you find another driver somatic mutation, that is probably the driver of the FEO, not this germline finding. I get that. What I'm not quite understanding is if we were able to do tumor sequencing and we did see that there was loss of heterozygosity, you're saying that would not be sufficient to reclassify the variant, but would it add anything to the case?
More anxiety, I would say. Possibly.
Yeah.
I know.
So,
I mean, I think so. We're talking about, so in the UK, where it's very regulated. So obviously, so our labs will only report a variant of uncertain significance if they're what we call a hot variant of uncertain significance. So which means that they're almost over the line. And I'm not sure, because I haven't looked up this variant, if this would meet that criteria or not. But
yeah.
for it to be a hot variant of uncertain significance. But what we're saying is that the loss of heterozygosity, if you look at the ACMG criteria, that wouldn't be enough to push that variant to the classification of likely pathogenic. So in the UK, we can only offer cascade screening if it's a likely pathogenic variant. So in the UK, we wouldn't be offering cascade screening even if she had LOH. But in your situation, I mean, I think, yeah, it's really tricky because TMEM127 penetrance is, from what we know, is very low within families as well. So, I mean, it might be worth doing and hope that it's negative, because that would be very reassuring for the patient, especially if you find it a driver variant. And then you could safety net that further by giving the family advice about symptoms that they should be aware about to present, to be screened if they did develop those symptoms, like what Helen highlighted in the presentation for SDHA, so hypertension or tachycardia and those kinds of things.
Yeah. Yeah. Which interestingly, this patient did, in retrospect, report. But you know, no one thought anything of it, I think, at the time, until she was diagnosed with the FEO. So it was kind of like, oh, I actually have been having some of those symptoms, tachycardia, and didn't know what it was from. I thought I had anxiety, that kind of thing.
Super interesting. I'm just looking at the time. So
Yeah.
I want to get to I think we'll only get to one more case. It'll be an SDHA case. But you guys, this is perfect that we got to present this case this time, because both Ruth and Helen are perfect to kind of advise on this TMEM 127 issue 2, which we are also seeing since many of the labs have started putting this on their large panels.
Yeah, thank you.
Thank you for your patience and presenting it this month, even though we weren't able to get to it last month. So thank you very much. Brenda, take it away.
So this case is an SDHA positive, and so this is interesting because we approached it, I guess now that I think back, maybe a little differently than what you recommend. But so this case first came to the medical attention because of a 1-year-old child who had a vascular malformation on his leg, I think. And so tumor testing was completed and they found an incidental SDHA variant that was later confirmed through Invitae to be germline. And so I saw the mom because she was interested in testing for herself. She was 33. She has a personal history of hypertension, and let's go to the family history. So here she is, 33, twin sister, no health issues. Her mother died of renal failure. There is some stomach cancer up here in the maternal grandmother. Not sure any details on that stomach cancer. So that's curious, a little interesting there. And then the patient's father also has a history of hypertension, and mother had ovarian cancer. But nothing else, no one else with any reported tumors other than this stomach cancer that, again, that she did not have any additional details and really no way of knowing of what type of stomach cancer she had. And so I guess my question to you, okay, so we did genetic testing. The mother was positive for the SDHA variant, and now we have a family that has no symptoms. It's an incidental finding. I think I pretty much went over, so I won't repeat the risks associated. I think I got some of this information from that paper, the recommendations. And so the way we approached it was they were really concerned about their second child. And so I go back to the family history. They were concerned about the second child, and I believe we agreed that we would offer testing, and then if with the hopes that the 4-year-old was going to be negative to provide some reassurance. And unfortunately, the 4-year-old was also positive. And so they're going to be connected and followed by one of our pediatric oncologists here at Vanderbilt. When they're older, we talked about screening would start right around between 10 and 15. And so now that I think about, you recommended an non-symptomatic family that you probably would not do cascade testing. And we did do cascade testing. We did cascade testing on the children. And so now I wonder if, obviously, the parents were very well informed. They wanted to know if the kids were positive or negative. They were not super anxious. They just wanted to know what symptoms to look for. I think we feel that we have a pediatric oncologist here that's very well versed when it comes to these situations. And so he's able to talk through the benefits and the risks of doing screening, and he can always come up with the personalized care. I think he supported the testing of these children because I think he was present when we presented this case. And so I just want to know what your take is on this, what you would recommend for this family. And I think other people are probably going to get tested. There is hypertension here. He's older, but the mom has hypertension. So we talked about that could be a symptom. You should probably be evaluated. And so she was referred to neuroendocrine for that. Any insight that you have on this case?
So we were talking a bit about this one last night, and Ruth, I didn't know if you wanted to talk about the vascular, the sort of.
I can. Right. So the first thing to say is I think in general, these cases are so difficult. I don't think anyone can say what's right or what's wrong, and it really is so hard, and especially when you have very anxious families. But so Helen and I have had these cases, and we were looking at them last night. And so what's interesting is that there has been some reports, mostly in mice models, so SDH knockout mouse models, and some anecdotal cases in the literature that SDHA variants can be associated with congenital vascular malformations, but that's more kind of accessory vessels rather than cutaneous vascular malformations or vascular tumors. When Helen and I were looking at this case last night, we felt that this probably wasn't a true SDH association, the vascular malformation, and this was more in keeping with an incidental finding of an SDHA variant. And Helen, I don't know if you want to speak about what we would do.
Yeah. So I think as I spoke through, there's a UK guidance. I guess we probably, thinking that this was not associated, we probably wouldn't have reported out that SDHA variant in the son in the first place. But sometimes obviously all that information is known. If it's reported, then we would review things, and I think we wouldn't have then gone on to offer testing to the other family members. So I think our view is that we probably wouldn't be offering ongoing surveillance for this family, and we would discuss with them about the low risks when you identify these variants incidentally in the absence of any suggestive family history. But obviously recognize that they're very anxious, and so one thing that you could consider might be a one-off screen, but that would be in adulthood, not in childhood. So there wouldn't be any benefit in doing lots of rounds of screening in childhood. So one-off screen round about, I think we're thinking sort of age 10 or something, Ruth. That might be
well, maybe even
helpful.
a bit later. Because some of the imaging starts for SDHA around kind of like 10 to 15, and I think if you want to do a one-off screen, and it sounds like you have an oncologist who's well versed in this, but if you want to do a one-off screen, then you want it to be of value. And if you think about how low the penetrance is of this gene in general, it's particularly low at a young age for asymptomatic carriers. So I think if you really wanted to reassure the family, but you're trying to minimize anxiety related to screens, because of course incidental things come up on clinical surveillance, then I'd probably push for that. For the child could maybe be seen and have blood tests maybe at 10 or so, and maybe a one-off whole body scan, maybe close to like late adolescence, maybe early 20s, and then, because at least at that point the child will then be an adult and will be able to have conversations and informed decision making about how they would want to proceed with screening, if they would want to proceed with screening. Would be my take. But I think that's what Helen and I kind of discussed last night, but it's really, really tricky.
Yeah, no,
Thank you.
Thank you.
Might be a dumb question, but if we figured out that we're past. If we figured out that it was
just to ask your question.
If we figured out that this came from that it came from the mother's side of the family, would you be concerned that stomach cancer was actually a gastrointestinal stromal tumor?
I guess in the UK we would have the benefit of being able to confirm that with a cancer registry,
Okay.
and so we would try and do that if there was any suspicion of doing that. So probably would be helpful, but it is. I feel maybe due to the age, it's probably more likely to be not a GIST, but it would certainly be helpful.
Thank you.
Yeah, no, thank you guys. And, I think this really serves to demonstrate how quickly the field is moving, the importance of these guidelines, because in the US, we are kind of in this situation where we don't have clear guidelines, in my opinion. So what Brenda did is what I would have done without the guidance from the UK consensus group, because NCCN is not really providing us with a bit more in terms of what do you do in the incidental situations where SDHA is being identified. So, as always, I applaud all these efforts from the UK that really do help us in the US. So again, many thanks to both Drs. Hanson and Casey for really a very informative case conference. I just wanted to look ahead. Our next case conference in June will be Presenter's Choice. So please submit cases that you want additional input on. And then in July, we have Megan Frone she's a joint counselor at the NCI, who's working on Ruth-Ramey syndrome. So I'm anticipating this is going to be a really, really interesting case conference as well, focused on Ruth-Ramey syndrome, which again is another area where we struggle with in terms of what are the best next steps. So with that, I know we are a few minutes over. Thank you again to our guest experts, and we will see you next time. This is our case conference schedule, and thank you for attending.